I'm one of the ICU physicians up in the Wake Forest School of Medicine here in North Carolina. I will be presenting the same lecture to you that I presented to my critical care fellows, pulmonary critical care, anesthesia critical care, trauma critical care, all kinds of critical care people. Thank you for giving me the honor of presenting this webinar. Over the next few minutes, we will go through the definition of sepsis because they have changed in 2016. We'll talk a little bit about epidemiology of sepsis, giving you the global and Indian perspectives. We'll delve a little bit deeper into the pathophysiology, but not in details, and talk a small amount on the clinical manifestations, not too much. And last but not the least, we'll come to the guidelines for diagnosis as well as management of sepsis. And bulk of the talk will be about the diagnosis and management. So sepsis is now defined as of February of 2016. Sepsis is now defined as a organ dysfunction caused by a dysregulated host response to infection. So infection is critical to this definition. The emphasis is on non-homeostatic host response to infection. And so looks like now they are putting a lot more emphasis on host response as well as to the incenting organism that incites all this in response. The reason to do that is because the potential lethality is considerably in the excess of the straightforward infection. So it's different from a little bit of, say, boil that then heals upon it within a few days on itself. This is a little more involved than that, and the body's host immune response is a lot higher than just a small sort of infection. And the reason to do this was a heightened need for urgent recognition, and you will be convinced of it by the end of a few more slides. So now septic shock is, they have taken it out, which they always did, as a subset of sepsis in which the underlying circulatory, cellular, and metabolic abnormalities are profound enough to substantially increase mortality. So this is essentially a subset of sepsis where there is a distributive shock or vasodilatory shock. This is essentially a clinical construct of sepsis in which you have a patient that walked into your emergency room or what have you, and you have given them adequate fluid resuscitation. But despite this adequate fluid resuscitation, you have persistent hypotension that requires now vasopressors to just keep the MAP at a reasonable level, say 65 millimeters of mercury, which is what is recommended. And in addition to that, you have a serum lactate level of greater than 2. So it's not enough to just have a mean arterial blood pressure, a vasopressor requirement to keep the MAP, but also you have to have lactate in addition to that to indicate the metabolic abnormality. With these criteria, the hospital mortality is in the excess of 40%. Depending upon what you read, it can go up from 48 to 50% in some cases as well. So how do you screen patients when they come into your emergency room? You're seeing them for the first time. How do you screen these patients, and who should be taken a little more seriously than just a little, say, boil? So for that, they came up with a Q-SOFA score. SOFA stands for Sequential Organ Failure Assessment. So now there is a heavy emphasis on organ failure, including acute kidney injury, which happens to be one of the early manifestations in this arena. So you see a patient for the first time, the patient gets 1 point for each of the following. Tachypnea, as in respiratory rate greater than 22 times a minute. Altered mentation, if the patient's confused or more confused than normal in some cases, and a systolic blood pressure of less than 100 millimeters of mercury. Mind you, here they have given a systolic blood pressure and not mean arterial pressure. So if a patient has greater than 2 points, that's when you need to be alert, or equal to 2 points, you need to be alerted. So here's how you use, I hope you can see this slide properly, but Here's how you use this QSOFA score. So a patient comes with a suspected infection. If you have a QSOFA score of greater than or equal to 2, then in that case, you should be assessing this patient for evidence of organ dysfunction. If the answer is no, then continue to monitor this patient. So once you assess, if the answer is yes, you assess for the evidence of organ failure or organ dysfunction by means of SOFA score, actual sequential organ failure assessment, which is given in box B. And there you are taking all different organ systems in failure, and these are the representative criteria to be used. PaO2 FiO2 ratio in case if they're intubated or not even intubated. Glasgow Coma Scale if they're confused. Mean arterial blood pressure less than 65. Administration of need for administration of vasopressors to keep that mean arterial pressure. Serum creatinine and urine output, I know, with all the bad things and sort of assessment controversies associated with them, these are the two that were taken into consideration for, especially the serum creatinine was taken into consideration for the original SOFA score assessment, bilirubin and platelet count. So if a patient has 2 or more of these, then in that case you are diagnosing them as suffering from sepsis. Now, you go down the road again to see whether or not they fit the criteria as we talked about earlier for septic shock, as in do they need a vasopressors, and if they have a lactate level of greater than 2 millimoles per liter. And if the answer is yes, then your patient is suffering from septic shock. So that's sort of the guideline that they have come up with in 2016. Just to give you a little bit of historic perspective, the consensus conference for, say, a sepsis on 2 sides of the pond, basically this was European and American, so North American consortium, and then that evolved the rest of the globe. And they came up with the sepsis definitions back in 1992. And that definition basically didn't change all the way until last year when they changed the definitions in 2016. So that's why I emphasize so much on the definition. Having said that, the data that I'm going to show you has used, obviously, for obvious reasons, has used the previous definition of severe sepsis, septic shock, etc. Septic shock has not changed, but now the severe sepsis from the previous definition has become sepsis in 2016 definition. So surviving sepsis campaign guidelines. So basically 10 years or 12 years after the first definitions were made, they came up with these, the consortium came up for the surviving sepsis campaign guidelines because the need was realized to early diagnosis and treatment of sepsis. So the first guidelines for this group, the management and diagnosis guidelines, came up in 2004. And these guidelines have been updated roughly about every 4 years. Ever since. And the management guidelines for sepsis are now, the latest ones are from 2016 that are published here as I've given you the reference. I'm not mentioning this reference anywhere else because you pretty much go to Surviving Sepsis Campaign Guidelines 2016 and the first thing that pops up is this intensive care medicine article. So from now on, whenever I talk about definition, unless I specify otherwise, it's 2016. And if I talk, more importantly, if I talk about guidelines, these are the 2016 guidelines that I'm referring to. Mind you, they're not that much different from 2012 guidelines. They just clarified a few things here and there. So why do we need to talk about sepsis at all? Because the burden of sepsis is obviously great. I'll give you a little bit of global statistics first, and then we'll come down to in data pertaining to India. Fleischman et al. Put together this data from 1979 to 2015, studying about 27 countries from 27 studies from 7 high-income countries. That was their database, and in that they decided, or they came up that they observed that the incidence of sepsis was about 288 cases per 100,000. So, however, the subset of it from 2003 to 2015, so this is post-definition, like a decade post-definition, that they started this 12-year data collection, where the incidence had gone up to about 437 per 100,000. And the reason for that is largely because of the increased awareness of sepsis. So in that, the incidence of severe sepsis, like I talked about, now that qualifies as sepsis with the new definitions, was 148 cases per 100,000, of which between 2003 and 2015, it was 270 cases per 100,000 patients. And mind you, the mortality of sepsis, which we don't even call as, may or may not call as sepsis, was 17%, but severe sepsis, which we call now as sepsis, is 26%. So globally, let's remember these two numbers, 270 cases per 100,000, and mortality with severe sepsis is 26%. Now compare that with this data that was presented in the International Symposium back in 2009 by Chatterjee et al. And the data consisted of 4 ITUs. Mind you, again, this is only 4 ITUs. This does not give a global perspective of what's happening all over India, right? But still, little perspective from India is that between 2006 and 2008, there were 4,183 admissions in the intensive care units, and SIRS with organ dysfunction. So total SIRS with organ dysfunction for any cause were 1,286, of which severe sepsis was 53.5%. Remember, I told you that from the global perspective, that incidence was not as high as that, right? And the mortality, which is where now you're comparing it to the 26% from the global perspective, now that was 28-day mortality was 53%. So more than double that of the global data that I just showed you. Mind you, these are only 4 ITUs. This does not represent entire India, and I'm fully aware of that. But this is just a glimpse into the data set. And the hospital mortality was about 55%. The same group presented or added some more patients and expanded this database and presented the year after that. And so now they showed they included about 5,478 admissions from the same 4 ICUs. Here the sepsis incidence was about 52% of all the SIRS patients, right? And that doesn't tell you, because it's apples to oranges. What I want you to remember is this severe sepsis mortality, which was 26% globally, is now 59%, at least in these 4 ITUs. So all I'm trying to establish here is it is a problem, and it is a global problem, not just US or India or whatever. This is US perspective. Now, the reason this is a very old NIH database, and the reason I show you this is because we see about here they are reporting about 300 cases per 100,000. Newer data shows anywhere from 400 to 700,000 cases a year, up to 1 million a year even in some years. And the mortality of severe sepsis is greater than that of acute myocardial infarction. And I am sure with the door to needle time and the door to balloon time, etc., this has gone down. I'm sure this has gone down considerably, and I know it has, whereas we haven't done much to severe sepsis. And the reason for that is multifactorial. The early recognition is the key here. So this is again older database. I'm not going to go into this in details, but we see about 300 plus thousand cases of mortality each year with sepsis, which was severe sepsis per definitions before. And in case of septic shock, this mortality goes up to greater than 40 to 45%, depending on what you read. I'm going to make it a little more pertinent to what we do every day. And I'm going to show you this gentleman, or describe this gentleman that I saw a few months ago in my ICU. This is a 24-year-old gentleman with no past medical history, young guy, was brought to the emergency room by his girlfriend with fever and altered mental status. He was suffering from, say, flu-like illness for about 2 or 3 days, and he started acting weird about 6 or 7 hours before presentation to the ICU, and that's when she got worried and she brought him to the ICU. She had noted cough for about a day prior. Upon physical examination, he was ill appearing in moderate distress. He was tachycardic with 110 beats per minute. His blood pressure is 93/63 millimeters of mercury. Mind you, his mean arterial pressure was maintained, but the systolic was less than 100. He was febrile, and he was tachypnic as well. So on physical exam, his pulse ox was 90% on room air. So other than a few crackles in his right basilar areas, and of course he was very confused. He was just disoriented time and space. All he could recognize was his girlfriend. But there were no focal deficits here. When we got his chest x-ray, of course, it showed right malignant lower lobe infiltrates. So here the diagnosis was pretty clear. It was right middle and lower lobe pneumonia. Does that mean he was suffering from sepsis? And the answer to this question was yes here, for two reasons. Because he had at least 3 out of 3 QSOFA criteria, and the main important one is because I'm presenting today, whatever. But so 3 out of 3 criteria. So he fit our QSOFA scores, and so he was further diagnosed to have sepsis. And we'll come back to this patient in a few minutes. So let's delve deeper into the sepsis pathophysiology here. There are 2 sides to this equation, right? There is the host side and there is the infective organism side, right? So the infective organism, all it has to do is put out a toxin or even die, and the cell wall products of it will secrete toxin, right? And a host response then puts out this generic inflammatory and coagulation cascade, which is supposed to be protective of its own organs, basically designed to preserve self, its own tissue, from the non-self, which is the organism that's inciting this huge response. So let me talk a little bit about the endotoxin, which is the main important thing that has been widely studied. That doesn't mean that's the only toxin that these organisms secrete, but as a representation, lipopolysaccharide, for example, from the gram-negative bacterial cell wall product, it has a O side antigen, it has a R core antigen, and a lipid A toxic moiety. It's a very simple molecule, as I'll show you in a few seconds. So basically, R core antigen, the O antigen, and lipid A. So it's a simple molecule that comes from the cell wall degradation, right? Look at us. What we do is we put out all these mediators of sepsis, ACTH, arachidonic acid, starting A to P, for example. Cytokines, complements, these are the most extensively studied ones. Nitric oxide, not to forget free oxygen radicals. So reactive oxygen species. And they, if you look on the right-hand side, a theme starts to emerge where the cytokines or nitric oxide, etc., they start now coming up with a theme of vasodilatation and increased capillary permeability, which then is responsible for your hyperdynamic circulation and shock that occurs. Later on in the course of the disease, of course, things change, and I'll come to that in a minute. Cytokines, by far, they're the regulatory proteins here, and they're secreted in response to all kinds of things: infection, trauma, inflammation. Body puts out this generic response because it wants to preserve self from non-self. And so these cytokines are secreted by all kinds of circulating cells, say lymphocytes, monocytes, neutrophils, and also the endothelial cells. So you can imagine the surface area that is secreting all these cytokines in response to just a simple molecule that the organisms put out, right? These are the different classes of cytokines that are doing that. Although tumor necrosis factor alpha is the most extensively studied one, this is just to complete the list that there are other things available as well: chemotactic factors, colony stimulating factors, and cytokines. And so this is just to break up the monotony. This is me in the mountains last weekend. This is a beautiful fall colors, and this week is just beautiful out here in North Carolina. Just bragging about it, that's all. So coming to the clinical manifestations here, there are some early manifestations that are different from the late manifestations of sepsis. Early in the course of the disease, you have very non-specific presentation. For example, nausea, vomiting, malaise, chills, fever, tachycardia, tachypnea, any viral illness, anybody with flu, which is going to be of no consequence, are going to present with these. So this is why diagnosis becomes very, very difficult, because how do you know going forward in a given patient who's going to be in trouble and who is not? And that's why we are not able to do, there is no troponin for sepsis, so to speak. There is no one test that will detect or that will, or three things that will sort of diagnose sepsis for you. Mental status changes by far would indicate earlier on in the course of the disease, and oliguria, which will take a little bit to establish. But mental status changes are one of the earliest signs, and you should be aware of those. The blood pressure even does not drop initially, because what you have is competing forces. You have vasodilatory shock because of the sepsis per se, the distributive shock, and now you have, if the patient comes later in the course of the disease, you have dehydration that's giving you a vasoconstriction. And so you're gonna, somewhere in the transition zone, you're gonna end up with a normal blood pressure. Even that doesn't help you. So that's why these are the factors that are responsible for delay in the diagnosis of this condition. So late in the course of the disease now, of course, you have cold extremities, you have oliguria, peripheral cyanosis, decreased cardiac output, increased vascular resistance. Well, guess what? By then, the horses are the barn, so to speak. You have not been able to prevent anything at this point. This is an up-to-date list that will give you all kinds of organ dysfunction, cardiovascular, pulmonary, renal, hematopoietic, neurologic, which occurred earlier, what we talked about. And so all these organ systems, to make it even worse, it is a system organ failure that kills patients with sepsis. The other important part of it to remember is every organ undergoes its own cycle of A versus state in any given patient. So no two patients are going to be similar. So now you don't realize how complex this whole thing is. So number hello? Hello? Can you hear me now? Okay. So later in the course of the disease, of course, you have increased early sepsis. Early sepsis will give you decreased vascular resistance and normal to low cardiac filling pressures, whereas late in the course of the disease, you will have intrinsic cardiac function, dysfunction with increased vascular resistance and low cardiac output. So again, late in the course of the disease, you have depressed myocardial function, right? And this is of note because this is one of the most important things to remember, is that it's a reversible cause for cause of myocardial dysfunction. You reverse the underlying cause, your myocardial depression will be reversed, right? Why do we need to care about this blood pressure or cardiovascular failure or what have you? Because it's all about the oxygen delivery to the tissue. The peripheral tissues will not see oxygen or will suffer from hypoxic or hypoxic damage. And that's what you're trying to basically avoid here. If you take nothing away from this lecture, there's one thing I want you to take away. It's all about tissue hypoxia. It's all about tissue perfusion. And the only couple of ways to assess that is, number one is your lactate concentration, and number two, oliguria. That's our urine output. Those are, and of course, mental status change. Those are the few things that will indicate to you whether or not there is an end organ damage or tissue hypoxia. The second one being, important one being pulmonary. Early in the course of the disease, again, very non-specific presentation and tachypnea, hyperventilation. Any patient with fever will have that. Going forward, it's very difficult to tell who's going to get into trouble. And even your chest X-ray will be normal in the beginning. Late in the course of the disease, of course, chest X-ray starts to become abnormal with alveolar damage and edema and ARDS-like picture. By then, again, the horse is out of the barn. We want to be diagnosing these patients early and not late in the course of the disease. The other organ systems that fail of importance are the hepatic dysfunction. And this, usually the acalculous cholecystitis occurs in the second or third week of the disease, but an important one to remember as well. And the GI bleeding. Renal failure, again, we know that it occurs earlier in the course of the disease. At least acute renal injury occurs, urine output drops earlier in the course of the disease, and that's what we monitor like almost constantly. Septic encephalopathy used to get less attention before. Now it's become a part of the definition, which heartens me because this is an important piece of the puzzle. This is what tells you that the patient is going to be in trouble going forward. And disseminated intravascular coagulation, oh, that's a late complication, and that is a dreadful complication. So what will you do next in our patient? Because unlike in outpatient services, you don't have the luxury of diagnosing your patient first and then treat them accordingly. That doesn't happen here. You have to have management and diagnosis occur simultaneously. So intravenous fluids were administered 30 cc per kilo via peripheral cannulas, and we gave him nasal cannula oxygen 2 liters per minute because his pulse ox was only 90% on room air. And of course, we administered some broad spectrum antibiotics. In our case, piptazo and vancomycin was administered. These are the basic laboratory tests that you will get in patients with sepsis, and like you don't, because you're trying to, basically you're going fishing. You want to know what's going on with this patient. So CBC with differential basic chemistry, lactate which occurs early, blood gas which occurs early, liver function tests, and toxicology screen to make sure that these patients are not confused because of something else. Of note, in my patient, the urine drug screen was completely negative, alcohol was negative as well. Urine exam and chest X, the microbiological tests such as blood, sputum, urine cultures, other appropriate cultures as are feasible as soon as possible, and then radiological tests as seen appropriate. So what are your priorities for management? Number one priority is hypotension. What does the campaign say about how much and what kind of fluid you should give? So early goal-directed therapy was like the best thing that ever happened to critical care back in 2001. And over the years now we've realized not so much. Too much fluid also kills patients. So, however, what is not gone away from literature is that we all agree some fluid resuscitation improves survival. So that is essential. The amount is controversial. And then the next thing you do is also simultaneously you identify the focus of sepsis, because you really want to get rid of the abscess, what have you. So get your appropriate cultures, imaging, antimicrobials, etc. And I'll give you the guidelines. I'll show you the guidelines about that as well. But and look for acids. And the third priority being assess for adequate tissue perfusion and look for organ damage. For example, acidosis, oliguria, mental status changes, etc. And then again, early intubation, that also becomes a part of the initial stabilization in case of the patient. Like in our case, the patient did not, but he could have easily gone into respiratory distress, and we could have had to intubate him as well. So try to intubate electively rather than emergency. And of course, coming back to the hypotension, fluid resuscitation, the initial resuscitation, what the campaign says is crystalloids, administer about 30 cc's per kilo body weight within the 3 hours. So now 2016 guidelines say this is what you should do. And unlike the previous guidelines, now they say that reassess your fluid status frequently. They don't give you any specific guidelines about what you should do. Whatever there is available for you, just go ahead and keep assessing the fluid status frequently. Check and see if your blood pressure has reached its goal, 65 millimeters of mercury for the mean arterial blood pressure. Other physiological parameters such as pulse ox, respiratory rate, temperature, urine output, lactate, and other things, you continue to reassess these patients frequently. They're not giving any specific guidelines about the CVP. They're not giving any specific guidelines for the hemoglobin, other than they say that try not to go below 7 grams per deciliter, which is, again, just a guideline. And so some studies are showing normalization. So keep giving fluid until normalization of lactate. There is very controversial data about that, and so it's a weak recommendation based on a very low quality evidence at this point. So basically, the campaign is leaving it up to you to assess fluid status frequently. Then if you have persistent hypotension after adequate fluids, which is 30 cc per kilo within 3 hours, then you start them on vasopressors. The campaign says, the surviving campaign, sepsis campaign says that norepinephrine is the #1, like your first line agent. Dopamine still appears on and off because historically we have much more experience with dopamine than any other vasopressor available. Vasopressin is now considered, or has been considered, as a second line agent for, for those patients who do not respond to norepinephrine adequately for large doses of it. The third thing that I want to talk to you about is glucocorticoids. Some of these patients you will come across patients suffering from the adrenal insufficiency. So how do you know which patients do that? There was a large controversy again started 2000-ish that continued on until 6 or 7 years ago as to who receives glucocorticoids. Now the Surviving Sepsis Campaign Guidelines says that if you have persistent hypotension, despite, say, fluids plus vasopressors for over 60 minutes, you've given your fluids, no response, you have given your vasopressors and increased or titrated them up, and large doses of vasopressors for about 60 minutes. Now you're thinking of adding another or a second line agent. Before you do that, or while you're doing that, take your blood sample again, send it to the laboratory for a random cortisol level, and then give them the first dose of glucocorticoids, which is the most studied is the in Corticus study back in Europe, and they studied 50 milligrams hydrocortisone Q6 hours. So give you 50 milligrams of glucocorticoid is what this campaign says now, and whether or not to continue it after 6 hours will depend upon the cortisol level. If your cortisol comes back as less than 20, yes, you need to continue with the glucocorticoids. But if it comes back over 20, then you do not need to continue with the second dose of steroid onwards. What does the campaign say? So what they are saying is the cultures of all the appropriate cultures, which is blood, urine, and plus minus whatever the abscess, etc., tapped before administration of my antimicrobial therapy. Having said that, if your LP or what have you, or the tapping of that abscess is going to take more than 45 minutes, don't delay that administration of the antibiotics. So if there is a significant delay, just go ahead and give your antimicrobials anyway. So initial empiric anti-infective therapy should be within 1 hour of presentation. Every hour that is delayed after that increases mortality in septic patients. So campaign says not to do that. One or more drugs that have activity against all the likely pathogens. So if you're suspecting viral, pull out that. If you're suspecting fungal, which will happen much more frequently, please go ahead and get your antifungals on board as well. And make sure that whatever agent you use, there is an adequate tissue perfusion to the presumed source of sepsis. And continue to monitor. Again, continue to monitor tissue perfusion with blood pressure, acidosis, mental status changes, school extremities. That is the running theme around here. continue to monitor. Again, this is not a typo. Continue to monitor your patient for the cool extremities and other end organ damage signs, decrease urine output, increase lactate, mental status changes, etc. Unless, of course, the patient is sedated. And that titrate your vasopressor to a goal map of mean arterial pressure of 65 millimeters of mercury. So coming back to our patient, after the IV fluids, his blood pressure actually dropped further, 88 over 45 millimeters of mercury. And the vasopressors were started, norepinephrine titrated very, very quickly to a map of 65 millimeters of mercury. We didn't need to add another vasopressor. And by the time I got this was all happening in the emergency room. The antibiotics were administered, like I talked about before, and his pulse ox also improved to 96% on oxygen, and patient was transferred to me, which is another story that then he got quickly intubated. But having said that, up until that point, the emergency room did the exact appropriate things that they was expected to do. So now coming back to our management guidelines, eradication of focus is what the campaign says, that get your imaging studied as soon as the patient is stable enough to do so. So in case the patient is stable enough to travel to the CT scanner, please do that. And the intervention for a source control, then again, they are saying that it should occur within 12 hours after diagnosis is made. And the effective intervention should be associated with the least physiological insults, as in minimally invasive techniques should be considered first rather than opening that abdomen. Right, and if the intravascular device, again, that's very pertinent to you guys, is the intravascular access devices are a possible source of severe sepsis or septic shock. Please consider removing them. I'm not, and everybody understands that permacath is not that easy to remove in some patients, and so at least consider the possibility. Glycemic control was another contentious area over the past decade and a half. What campaign currently says that employ a protocolized approach and monitor glucose values every 1 to 2 hours until the glucose stabilizes, and then every 4 hours, and start insulin drip if there are 2 consecutive blood glucose levels are greater than 180. So 180 or below should be the goal as suggested by the campaign now. Nutrition. When do you start nutrition? Early. Within 48 hours, enteral nutrition is always preferred. It's a no-no to parenteral nutrition unless it's absolutely necessary because the gut is inactive. Immune-enhanced nutrition is very controversial, and currently it is not recommended. There is no good data to prove that it really actually helps. The most important part of this is, again, de-escalation of antimicrobial therapy. That's what I keep hammering into my favorites all the time. Is you have started these patients on empiric antibiotics. You don't want to run into the trouble later on. Assess those antimicrobial coverage every single day. If your cultures are back as negative, stop them. If your patient is not improving and you feel like continuing that empiric therapy, at least there should be a discussion every day as to when can we stop it. And if it's clearly empiric and it continues to be empiric, 3 to 5 days is good enough. Unless, of course, special circumstances, so the patient is slow to respond, or undrainable focus of infection, or if there is a bacteremia with Staph aureus, then they have about 2 weeks of IV antibiotics anyway. And some fungal and viral infections in immunologically compromised patients. So in those cases, you can longer courses are needed. DVT prophylaxis, again, these are for completion's sake, pharmacotherapy with low or unfractionated heparin, and sequential compression device if the anticoagulants are contraindicated in some cases. At least SCDs have to be done. Bicarbonate, again, that used to be done routinely. We don't indicate that. It's not been indicated for at least 8 or so years, unless the pH is less than 7.15 and the patient is hemodynamically compromised. And in that case, you may consider it, but not as a routine procedure for hyperlactatemia. Stress ulcer prophylaxis, again, if septic shock is associated with the bleeding risk, yes, you can do either H2 blockers or PPIs. But if there are no risk factors, don't do it. With that, I'd like to stop and brag some more about the fall colors here. and I'll open up for questions.